we have very experienced faculty. Sartaj Grewal is the second generation from Dr. S.P. Grewal's center in Chandigarh, where they have a large experience with refractive surgery. And I think we start off with pre-operative evaluation for Lasik. Dr. Khokar, will you join us? Huh? Come. Grewal, sir.
Good morning. I would like to start by thanking Dr. Shashi Kapoor for giving me the opportunity to be a part of this instruction course. Today, let's learn the approach to interpreting corneal topography and pachymetry. Corneal topography and pachymetry are the foundation for successful refractive surgery and a happy patient with a stable cornea. There are three techniques for determining corneal topography. The first and oldest is the Placido-based and began with the Placido disc, and was followed with the video keratoscope. The next is slit scanning systems utilized in the OBSCAN as a combination of slit scanning and Placido imaging. The third and the most popular used technique is the Scheimpflug imaging and is used in the Pentacam, the Sirius, and the Galilei. Modern topographers provide us with an overwhelming amount of information. It is easy to get lost in the maze created by all this information. Even the basic 4-map refractive display gives us the elevation maps for the interior and the posterior cornea, the corneal thickness, the interior curvature map, different data about the interior and posterior surface of the cornea, the corneal thickness displays, and anterior chamber data. It is important to enable us to browse and analyze this information in an efficient manner. And to do so, it is crucial to adopt a strategy. We'll start by first the basic, which is confirm the identity of the patient. It is very important to make sure that you are viewing the reports of the same patient that you intend to operate upon. Next, confirm the quality of the scan. In the quality specification, it specifies the quality of the data captured. It should be a white box with OK. Otherwise, there is some missing information which has been extrapolated by the machine and will be shown in a yellow or red box. In this case, the capture must be repeated. Next, we look at the pachymetry. The pupil center is the corneal thickness which corresponds to the center of the pupil, and its locations and coordinates are important to evaluate angle kappa. The pachy-apex represents the thickness at the apex of the cornea. The computer considers this as the origin of the coordinates. The thinnest location is the thickness and location of the thinnest point of the cornea. The difference between the thinnest location and the pachy-apex is normally less than 10 microns. The y-coordinate is most often normal when it is less than 0.5 millimeters, and suspicious when between 0.5 and 1 millimeter, and abnormal when it is more than 1 millimeter. Compared with ultrasound pachymetry, which measures thickness at only 1 point, the Pentacam can generate 50,000 data points to describe the true thickness. The normal pachymetry map has a concentric shape. Next, we look at Kmax. The maximum curvature diopter of the whole interior surface of the cornea expressed in diopters. A value below 47 is suitable for refractive surgery, while a value between 47 and 49 is a moderate risk factor. Next, we look at the Q value. The Q value is defined as the radial change from the center to the periphery of the cornea. It reflects the shape of the cornea, its optical properties, including the refractive power, the spherical aberration. Normal values range between -1 to 0. More than 0 would be seen, values less than 0 would be seen in oblate corneas, and less than -1 in hyperprolate corneas. Such corneas are at a risk of higher spherical aberrations. Next, we look at the anterior curvature. The anterior curvature map represents the anterior surface dioptric power measured by the sagittal method. One normal pattern is the symmetric bow tie seen here. The flatter cornea appears in cooler colors while the steeper cornea appears in warmer colors. We can see many different shapes over here. Normal shapes which do not predispose a patient to the risk of ectasia, such as round, oval, symmetric shapes, and at the same time asymmetric shapes and irregular shapes which have a very high risk of ectasia. It is important to choose the correct settings for displaying the colors in the curvature map. A 0.25 diopter step can lead to a lot of noise, while a 1 diopter step leads to a washout of all the details. A half diopter step has been suggested as the ideal value that represents all the information we need. Next, we look at elevation-based tomography. Now, while placido imaging is useful in determining the surface corneal curvature, elevation tomography is what helps determine the overall corneal shape and the spatial thickness profile. In order to make elevation data clinically useful, it is displayed against a non-planar reference surface. A reference surface, which is typically a sphere, is constructed by fitting the reference surface as smooth as possible to the data surface, the best fit sphere. To help us understand this, what a best fit sphere is basically doing is changing the x-axis on a graph that is representing all the data. Over here, if we change the x-axis to this, it's much easier for us to help understand what this data means. It is then clinically useful for us. Elevation maps which are normal will show a symmetric hourglass pattern. We can see abnormal patterns such as tongue-like extensions or irregular patterns. The color scale for elevation maps will be green if it is matching the reference best fit sphere, red if it is anterior to the best fit sphere, and blue if it is posterior to the best fit sphere. Normal values less than plus 12 microns will display as green. Suspicious areas between plus 13 to 15 microns will be yellow, and areas that are more elevated than 15 microns will appear in red. In the posterior surface, again, anything up to 17 microns is displayed in green, anything between 18 to 20 microns is displayed as suspicious, and more than 20 microns is red. In keratoconus, we will see an island of elevation, both posteriorly and anteriorly. We can also use differential maps, which help us to track stability of the patient over time by allowing us to compare two scans simultaneously on one screen. Next, we look at the Bellin-Ambrosio deviation index, the BAD display. In the Bellin-Ambrosio BAD display, what we see is first we have the two standard elevation maps, which display the baseline relative information of the cornea with the best fit sphere. Next, below them are the anterior and posterior exclusion maps. These are enhanced elevation maps which display elevation data with the best fit sphere recalculated using all the raw elevation data, which is outside a 4 millimeter circle, which is centered on the thinnest point of the cornea. The difference elevation map shows us the difference between the normal best fit sphere and the optimized best fit sphere. Areas that are normal with a difference of less than 5 microns will be displayed in green. Areas that are suspicious between 5 to 7 will be yellow, and areas that are highly suspicious will be more than 7 microns and displayed in red. The D value that is displayed has 5 components. We have the DF for the front surface, the DB for the back surface, the DP for the pachymetric progression, DT for the thinnest point, DA for the thinnest point displacement. The final D parameter, which represents the overall reading of all the 5 parameters, is performing a regression analysis against a standard database of normal and keratoconic eyes. Normal values of up to 1.6 are suitable for refractive surgery. Suspicious values between 1.6 and 2.6 will appear as a yellow box, and it is ideal to first reconfirm the data by performing the scan once again, and then decide if the data is accurate or not. Patients who have values more than 2.6 and are displayed as a red box are abnormal. The thickness profiles that are displayed will be the corneal thickness spatial profile, which describes the average progression of thickness starting from the thinnest location to the corneal periphery. The percentage thickness increase describes the percentage of progression of the CTSP. The red line is the data of the examined cornea, while the black dashed lines represent the double standard deviation of the corneal thickness. A normal profile will follow the shape of the black dotted lines while not necessarily conforming within them. Now, ectatic corneas thin more rapidly as you progress from the center to the periphery. So these curves help us differentiate between a normal thin cornea and from one with early ectatic disease. Normal values for thickness profiles are between 0.8 and 1.1. Thickness profiles more than 1.1 are suggestive of ectatic disorders, while thickness profiles less than 0.8 can be seen in edematous corneas or sometimes in pellucid marginal degeneration. A quick slope like this, where the red curve leaves its course before the 6 millimeter zone, is very suggestive of either keratoconus or ectatic disorders. Similarly, with an S-shaped curve. The Ambrosio relational thickness values, the ART values, it is a ratio of the thinnest pachymetry and the pachymetric progression indexes at different meridian. A value more than 400 is very safe for refractive surgery, while values less than 400 are very suspicious. Let's come to a few cases. The first case, so we'll start off by identity. Next, we come to the quality, which in this case is okay. Then we come to the pachymetry, where at the center of the cornea, it's 566. The thinnest point is 562. Both are normal. The difference between the two is less than 10 microns, and even the Y location is less than 0.50. The Q value in this case is minus 0.39, which is optimal. The anterior surface curvature appears normal with a symmetric bow tie. The K max is 44.9. The interior elevation, all values are within the normal range. The posterior elevation also the same. The bad display also is only 0.54. That would be a suitable case for refractive surgery. Next, we come to a case, again, the quality, the specification is okay. The pachymetry values are 465, thin is 433, not suitable for refractive surgery. Although the QS value in this case is within the normal range. The interior curvature shows a claw shape. The K max is 48.6. The interior elevation is plus 28. The posterior elevation is plus 47. The bad display is 7.41. Definitely not suitable for refractive surgery and should be considered for keratoconus. Another case like this, where we can see, again, the quality specification appears okay. The pachymetry all appears within normal. The Q value is also normal. But the anterior curvature shows a symmetric bow tie, but just against the rule. Again, the K max over here is 47, which is borderline. Anterior elevation is plus 3. The posterior elevation displays an irregular pattern. The ART max value is less than 330, is less than 400. Again, very suspicious. The PTI average also is 1.2. This is a patient where ideally you should repeat the scan, and if the data is similar, you should counsel the patient that he's at a higher risk of ectasia. Coming to pachymetry. There are two basic techniques for pachymetry, which will be optical pachymetry or ultrasound pachymetry. We have the Scheimpflug, the slit scanning, and AIOC and specular microscopy in optical pachymetry. Studies have shown that all of them have a high correlation, though low interchangeability. And for most cases, whatever machine you're using for a topography is the same that you'll also use to obtain your pachymetry values. To end, it's very important to measure twice and cut once. Most cases who will present with ectasia will be cases that were borderline on topography but were missed in the preoperative evaluation. It is very important to repeat the test wherever you have any, even a low index of suspicion. Confirm before you proceed. Thank you.
That was an excellent overview of entire topography and pachymetry. Mind you, pachymetry has become almost like an industry, you know, the number of indices and all. Olden days, we just had an ultrasound, a pencil, we just took a pachymetry. And I think, are there any questions on topography or a pre-op evaluation? This is a very informal thing. We can take the questions now, and there are a lot of experienced things. Anybody has any clarification on preoperative evaluation?
No, once you are doing pentacam, then it takes care of it. You don't need a separate pachymetry. No.
The one scan for the thickness itself, it takes insight into the periphery. So this is the machine which covers everything for the refractor.
Let's say if I want to, take your question a little further, Sartaj. If someone has a normal ultrasound pachymeter already and he doesn't have access to a Scheimpflug type of, 100 indices of pachymetry, so what should he do?
Well, yes. In that case, the gold standard is the ultrasound pachymetry, and
So you can feel confident and use that.
not ideally, because the ultrasound pachymetry will give us only one point of reference.
Sure. I'm saying, but
Yes.
like almost 10, 15 years, we did refractive surgery with just ultrasound pachymetry.
Yeah.
How many cases went into a serious problem, or this is a very recent phenomena of having 22 indices for pachymetry.
Yes.
Facial thickness profiles and all that. So,
I think if I understand the question properly, if somebody is doing refractive surgery and he has only ultrasound, then my suggestion will be buy a pentacam.
And I think there's so many variations when you do the ablation, but touching, touching the thing compresses the tissue. So you will not have an actual tissue. You're not supposed to touch the tissue. Leave it a virgin tissue, then take the data from there. And what Dr. Grewal said is right. You shouldn't do it. I mean, it's not right. The good old days, yeah. And the problem is that if you pick up a very thin cornea, very thick cornea, you can be happy. But the ones which are borderline, which your pentacam can help you to go, why not do it? And tomorrow, if you have a medical legal issues, I think nobody's going to help you out there. So please buy one. No financial investment.
how many people have access to only Placido topographer? There are centers which have not, progressed to going in for a slit scanning or this. So what would be your advice, Sataj? The older centers who have not upgraded to a pentacam, they still have a good Placido topographer.
They should upgrade.
You and Dad have got the same answer. Rajesh?
The whole-
So topographers, those who have not upgraded to slit scanning or a Scheimpflug, and they're using a Placido, a good Placido topographer.
Yeah.
So what advice you've got?
Well, majority of cases you're not going to have any issue, but there will be a few cases wherein there will be some doubt. That can be cleared by the modern topographers only, like the pentacam. And even if there is some doubt in pentacam, like there are certain situations wherein we are in some doubt in pentacam also of, maybe a borderline situation, then Fourier domain OCT can help us to know the epithelial thickness mapping. And when we do epithelial thickness mapping by Fourier domain OCT, if the thickness of epithelium is selectively lesser in the inferior temporal, inferior nasal part of the cornea, then such cases should be observed for some time and repeated pentacam.
Can I enlarge this? Like, so I think you're doing intracorneal ring segments or something. Okay, but the elevation maps are especially useful, say in femto pockets or intrastromal ring segments, and where they, besides screening, in screening, of course, as he pointed out, all those values are there: front surface elevation, back surface elevation. So I think Jeevan, you're next, and thank you. Yeah.
Dignitaries on the dais, Dr. Shashi Kapoor, AIOS office bearers, seniors, teachers, and dear friends. Refractive surgical techniques and post-op management. There is no financial interest in this presentation. Exam laser procedures. Lasik is laser in situ keratomyolysis, and surface ablation is named depending upon how the epithelium is removed. If you are going to remove it with the blade, it is called as a PRK. If it is going to be removed by alcohol, it is called as a Lasik. If it is to be removed by microkeratomy, it is called as epilastic. And the next generation of surface ablation is called as ASA, or advanced surface ablation, and it has got a components of use of Mitomycin-C 0.02%, using chilled balanced salt solution, and using a bandage contact lens. So advanced surface ablation, what's the technique? Preferably put 4 to 5 times proparacaine that loosens the epithelium prior to surgery. Inside the OT, we use 20% alcohol for 20 seconds with 8.5 millimeter cup and kept for 20 seconds. This removes the epithelium very easily. After that, give a thorough balanced salt solution wash with a chilled BSS. Then do the laser procedure. Again, give a chilled BSS wash. Then apply Mitomycin-C 0.02%, 12 to 30 seconds. Some follow 10 seconds per diopter. Again, give a chilled BSS wash. Put antibiotic, bandage contact lenses put for 3 to 5 days. We give oral vitamin C for 15 days, analgesic depending upon the pain. Soft steroids are given for 48 hours, after 48 hours, and tapered over a period of 4 to 6 weeks. Antibiotic for 8 days, and lubricants for 6 to 8 weeks. Lasik can be a standard Lasik, which creates a flat or oblate surface, or it can be Wavefront optimized. Optimized means creates a spheric shape and not the flat surface. Or it can be Wavefront guided, where you have to use the abrometer and detect the changes. Femtosecond laser Lasik, also called as a bladeless Lasik, and then relax smile and flex. Relax smile removes the lenticule from the cornea, while flex is just like a Lasik. Instead of doing Lasik excimer laser, we create a flap like a Lasik, and the lenticule is removed just like what we remove into relax smile. So in Lasik, what you do a microkeratom pass, IOP is increased more than 60 millimeter of mercury, which can cause blackout, so inform the patient beforehand. Swipe the stoma with a blunt instrument, so that removes the excess fluid. Any fluid near the canthus is removed, so that will not hamper into the action of the laser. And do laser procedure now, reposition the flap, give balanced salt solution wash under the flap, so all the debris is washed out. Inspect the flap properly, and you can give a drying time of 2 to 3 minutes, which will attach the flap to the stoma. Antibiotic steroid is given for 1 week, lubricants for 4 to 6 weeks. Cyclosporin 0.05% for 6 to 12 months for a previous or a chronic dry eye or contact lens wearers. Now, what is Lasik? A primary Lasik, that is simple standard Lasik, treats only refraction. That is your sphere and cylinder. But it can add spherical and higher order abrasions. Wavefront optimized Lasik creates a spheric shape, not the oblate shape. It treats the refraction plus spherical abrasions, but there is no need of any abrometer. So this treatment can be done as a standard treatment. Now, Wavefront guided Lasik, what it does, it is a customized Lasik where the sphere and cylinder is treated instead of 0.5 diopter, 0.01 diopter. So refraction it treats the spherical abrasions, it detects the higher order abrasions, you need an abrometer, it treats everything with more accuracy as far as the alignment concerned by iris registration and pupil centroid shift compensation. Whenever pupil constricts, it moves nasally and little bit upwards. So this is tracked by the machine and treats, so the accuracy is better. भैया वीडियो क्यों नहीं रन हो रहा है? जी हाँ, ये नीचे कैसे लेंगे? नीचे ले लो. I'm sorry. तो पीछे का वीडियो में दिखा सकता हूँ, निकाल लेना. Idea is to see that if you can see there are slight movements, they are called as saccadic movements. Sorry. Chala. I'm so sorry. Basically, whenever you take a flap by microceratum, you can have either a superior flap or a nasal flap depending upon the microceratum you are using. Most of the Moria microceratum takes the nasal hinge, while XP or Bosch and Norm takes the superior hinge. A lot of debate that which one is better and which is causing less dryness by cutting the horizontal nerves. But so many studies have been done, but both are almost on the par. So whatever you have, you can just have your own preference as a surgeon.
ओपन हो रहा है
नहीं तो उधर का वो पावर पॉइंट वाला किया था वो ओपन करो ना पहला. The most famous camera which is used, yeah,
Is it, you
it's
want to
working,
sort
it's
it out?
working. Yeah, yes, sir. Just 1 minute.
Okay, otherwise, if it's
I'm going
not
to the
done-
next slide by that time.
Yeah. So I think, Jeevan, could you sort it out? We'll take the next talk. Yeah? हो रहा है? हो गया, thank you.
हो गया क्या? Till that time we'll see, शुरू होने के बाद बताइए आप. Okay, what we do in the relaxed smile is the PI or patient interface is used and that remains between the machine and the eye of the patient. So once you dock the PI, then IAP is raised less than 30-40. Unlike Lasik, the pressure is not increased beyond 30 to 40 millimeter of mercury. So patient will keep on seeing the target light, so there is no blackout. It cuts in 4 plane by femtolaser, that is anterior lenticular plane, posterior lenticular plane, side cut of the lenticule and the incision. Then you can dissect the lenticule and remove it. Interface is washed and gentle massage is given from the epithelial sides. At both the surface which has got a crenated border created by the air bubbles gets straightened out and the vision is better. Treatment is just like Lasik, antibiotic steroids for 1 week, lubricants for 4 to 6 weeks, and as I said before, cyclosporine only in a patients where you know you can do have some issue with this. We'll just see the slides first, and if possible, we'll come to the videos later. Now, what is Wavefront guided laser? What it does basically, it creates a map instead of a refraction. That map has got lower order aberrations, which is a spear, defocus, and astigmatism, and higher order aberration like spherical aberration, coma, trefoil, everything else. So instead of feeding your refraction to the machine, this map goes to the machine and it does the treatment. Yeah, treatment is also not seen, we'll come to that later. भैया वीडियो रन होने के बाद बता दीजिए, सब वीडियो रन कर दीजिए आप एक एक करके ताकि दिखा सकेंगे. Till that time, since this is only on a Lasik, one single point which I would like to mention as far as Pachymetry is concerned, that patients who are high myopic are not suitable for the Lasik or contraindicated for the Lasik. Their Pachymetry is used. The most important, हाँ जी करो करो. So Pachymetry gives if you can see, these are the saccadic movements. So you need a 3D eye tracker which tracks the eye horizontally in X and Y direction. Play karna bhaiya. So these are the saccades. So that's why we need an active eye tracker. Active eye tracker will track the eye for 3 millimeter. That is 1.5 millimeter on the either side of the center of the eye. So once it goes beyond 3 millimeter, the tracker stops automatically, and as soon as it comes into focus again, it will restart. That is what is called as an active eye tracker. And you reposit that back. Next video. हाँ वो रन कीजिए, उसके पहला वाला, उसके पहला वाला, हाँ ये रन कीजिए. Relax, I just want you to see because It's a relatively new technique compared to the Lasik, which is
Even
around
we
from
have
2000.
we have another talk on
Okay, okay, great.
Yeah, yeah.
उसके बाद वाला ले लेना, अगर रन होता है तो. स्लाइड शो करो. उसके आगे वाला लेना. रिलेक्स तो कोई और बात करेगा, आप दूसरा बताइए. हाँ, दूसरा है. This just shows that once the map is fed to the machine, how the treatment is done. The overall importance of customized treatment is to create a point focus onto the macula. That was what gives a more crisper image, which is 6 by 6. But पहला वाला, आप पीछे जाइए. So it converts the basically image and map into a sharp point onto the macula, which gives a better than 6 by 6 vision, which has been misnomed or more hyped as a supervision or eagle vision. But primarily what it does, it treats the, ऊपर जाना भैया. We'll just wait for 20 seconds. If it is not running, we'll cut it off. ऊपर जाइए. एकदम ऊपर जाना, एकदम. हाँ, ये वाला. हाँ, ये रन करना फुल इसमें. वैसा रन किया तो भी चलेगा.
जीवन
ऐसा ही करो. See, basically this is the wavefront map which we showed. So it is converting and treating and creating a small point onto the macula. This is what gives you a better than 6 by 6 vision, or been hyped as a, we can say, eagle vision. So basically treating lower order aberrations or higher order aberrations to create a better image onto the macula. Thanks a lot. Thank you. Sorry.
Thank
for
you,
the-
thank you, Jeevan. This is a very important, he has covered all the procedures. What is important is, since 2 days, I'm happy that in all the sessions I'm seeing a lot of talks that Lasik is now no more. Back to the surface, back to the surface. Surface treatment is being come very vociferously back. Now, it might not be in a high-tech center like Dr. Grewal and things like that, but I am seeing in my own city, and I'm traveling a lot of people are going back to just doing a surface treatment, no flap. So before Dr. Rajesh Sinha's topic is corneal haze after surface ablation, the one thing that frightens a doctor from doing surface treatment is the excess reaction, and almost when excess is a corneal scar. After his talk on this, Professor Sinha has got a maximum experience and from All India Institute, and I'm very grateful to you, sir, for having joined this, and then we'll discuss this topic. Thank you.
Thanks, Dr. Shashi, for having me in this wonderful course. I'm telling you, whenever I speak about corneal haze, those who are, very much for surface ablation, they immediately react that, no, we are not having in our patients. So whatever I'll be talking, it will be based on my own experience at RP Center, where Dr. Khokar has also loads of experience, and also on the existing literature, which is evidence-based. So corneal haze, these are the surface ablative procedures like PRK, Lasik, Epi-Lasik, and it has been noted in these, I've just mentioned a few of these studies. These are some of the studies that I've mentioned, that the surface haze is seen in many PRK patients, which starts after a month, then increases, and then fades off in many, but it persists in some of these patients. This is something which this is the post-surface ablation haze. Now, it is mainly related to high myopic correction for more than 5-6 diopters, hyperopic correction, astigmatism, based on these literature. And when the ablation depth is more than 80 microns, when you are doing retreatment or enhancement of surface ablation, then when somebody has undergone a previous corneal surgery, and most importantly, somebody having ocular surface disorder, because it is directly related to inflammatory mediators, and when there's an ocular surface disorder, inflammation, subtle inflammation is already there on the ocular surface. So this haze is basically because of the exaggerated corneal healing response. Whenever there is an epithelial injury, when you debride the epithelium, there is a release of inflammatory mediators, and then there is some inflammation because of the ablation of the keratocytes as well as the Bowman's. It has been, Bowman's has been found to be one of the implicating factors. When you ablate it, there's risk of proliferation of remaining keratocytes, and there is synthesis of the new extracellular matrix, which causes haze. What happens that these are not the routine keratocytes, they form myofibroblasts, and which are not clear, which cause haze formation. Now, there are basically two types of haze. As I said, that in some of the patients you have a transitory haze which fades off with time, and in some you have a long-standing haze. Now, how will you quantify haze? First of all, the basic method of recording visual acuity. When you record visual acuity, record the quantity and quality of vision. That will give you an idea. And then on slit lamp examination, you can have a visibility behind the haze. That gives you an idea. Then, of course, confocal microscopy and Schimflug imaging, these can help. Now, this is the confocal microscope of a normal cornea, and when post-PRK haze, you can see these highly reflective matrix which are seen interspersed. And this gives you an idea that there is presence of haze. So how do you manage a haze? Of course, one should be preventive management is the best. Like when you're doing a surface ablation, one should use Mitomycin-C. Now, literature says that whenever you ablate higher, the risk of haze is higher. But I'll just come to one literature which talks about less than 3 and more than 3. But even in less than 3 diopter of myopia, haze has been reported. So preventive management, I would say, in any case of surface ablation, one should use antimitotic agent like Mitomycin-C. And if at all there is a haze, then we have to treat it medically or surgically. And surgically, what we have to do, I'll just come to that. Now, whenever you have a high correction, one should definitely use Mitomycin-C. And Mitomycin-C, again, there's variable response. People use 0.02% for 30 seconds, for 1 minute, for 2 minutes, depending upon the amount of refractive error. And some people go for a lower strength also. 0.01%, 0.002% has also been reported. But they increase the duration. The basic concept that they have in mind is that if you allow the Mitomycin-C to get absorbed onto the surface, you give time, but at a lower concentration. So the complication will be less, but with a higher duration, it will get absorbed into the surface. Now, this is a US Army study wherein PRK with Mitomycin-C 0.02% with 30 seconds was done, and they found out that it is absolutely safe and no side effect was seen. In order to prevent haze, a lot of efforts have been done, like vitamin C. We have been prescribing vitamin C when we were doing Lasik very often, PRK very often. Then high-dose vitamin A, then topical steroid is useful in order to reduce. There are some newer modalities like plasma-rich growth factors, topical interferon, and some gene therapy. I don't have personal experience of that. These are the literature which states regarding TGF-beta inhibitors also, since it is involved in the healing process, by use of this is an in vitro model, no human study has been done. They found out that TGF-beta 3 inhibitor can help in preventing haze. This is one study which has concluded that in eyes wherein you are correcting for more than 3 diopters of myopia, 1/3 of patients will have haze in spite of use of Mitomycin-C. Now, this haze can be clinically significant, can be clinically insignificant. But today is the era when we use premium IOLs, and these patients will have to undergo cataract surgery. And if the haze persists, then use of these multifocals, the ERVs or trifocals will have issues in these patients. Now, as far as surgical treatment is concerned, we can do PTK, we can debride the epithelium, do PTK, and use Mitomycin-C. Now, coming to post-Lasik regression, another topic which I have to cover. The regression means a tendency of the eye to return to its original refraction. Now, this can be because of the epithelial hyperplasia, increase in it has been found that in a patient wherein there is regression, there is epithelial thickness increase as well as keratocyte hyperplasia, and that results in regression. Another cause which has been included in regression is ectasia, and if you have, and all these are related to the increased ablation. If you are doing a surface ablation or a Lasik, whenever you are doing more of ablation, the chance of regression is high. So that's why in high myopias, the risk of regression is high. In lower myopias, the risk of regression is very low. Now, if the patient does not have ectasia and just a keratocyte hyperplasia and epithelial hyperplasia, in such case, retreatment can be done. You just relift the flap and then go ahead and do it. Now, with the advent of re-Lasik, we have always either we lift the flap, and if it is not possible to lift the flap, we go slightly bigger and slightly deeper. But with a femtosecond laser, we can modify the flap by any way. We can go even smaller, we can do side cut within the previous flap and go ahead and do it. We can even make a thinner flap and we can go ahead and do it. So basically with a femtosecond laser, you can modify your flap and do it. Surface ablation is another option for regression. And this is all about what I said, that when you are using a femtosecond laser, you can modify your flap. You can do a vertical side cut within the previous flap and go ahead and complete the procedure. Now, if you have a regression because of ectasia, in such a case, it behaves like a keratoconus, and the best option in these cases is a RGP contact lens. So RGP contact lens works very well, the rose K contact lens, the SOPA design. Another procedure which has been found to be very effective and providing good satisfaction to the patient is intracorneal ring segment combined with cross-linking of the cornea. So this is an example of a femtosecond laser-assisted intracorneal ring segment implantation. The suction ring has been placed, and then the cornea is applanated. And then this is how you, this is actually, I'm sorry. The cornea is applanated, and then the femtosecond laser is fired. And this is how you create the track. Now, once you have created the track, you open the radial incision first, and then you open the initial part of the track with a mechanical separator. And once you have done that, you open it on the other side, and then you put the ring segment, one ring segment placed, and then you put the second ring segment, and then you tie one suture to close the radial incision so that it doesn't exteriorize. Then you debride the epithelium within this area inside the intracorneal ring segment, and then put riboflavin, and you can do an accelerated cross-linking in this case. So what I meant was that intracorneal ring segment is one option, and perhaps the post-Lasik ectasia is considered as the most, number one option for intracorneal ring segment with cross-linking. So these are some of the options which I discussed, and I would like to have the opinion of the panelists.
Thank you for covering it extensively, Rajesh. First thing is, here, Dr. Coker, you're doing surface treatment? Yeah. Dr. Grewal? Not at all. Now, we have...
I don't do less, I only do smile.
Yeah. So, Dr. Coker, let's start with what Rajesh sort of pointed out, that you can get haze even in someone with less than -3. So it's totally a random thing, probably. We can describe it as something random. So what would be your guideline if someone does even a -3 or a -4 surface treatment? What post-op regime, and what would you, how many months of steroids, and what would you sort of guide.
I think Rajesh has covered it very well. See, the basic issue is that you don't want the keratocytes to intermingle with the tear, which is changed now. And the moment you have cytokinins coming and going inside, they intermingle with the keratocytes. The deeper you do, the more the reaction is, because the more enzyme is going to go inside. So superficial, the lesser ones should not have it, but as he rightly said, each patient will have a haze if you look for it properly. And yes, the deeper you go, anything more than 3, when it started, people were doing -10 with the Mitomycin-C 0.2, keeping for 2 minutes on the cornea, I don't know, which was so bad for the cornea. But now gradually people have become wiser and they started reducing the concentration, but I think most of them will have it, even up to 1 or 2 can have it. The difference between the PRKs and the Lasik basically is, Lasik, you have a flap on the top, but the flap is not adding to the strength of the cornea. Whereas when you do a PRK, whatever the residual is there is actually adding the strength. Entire strength is because of that. So that way it's a good procedure. And the first issue is, in PRK, you're measuring on the surface.
Can I interrupt you, Dr.
Yeah, sorry.
Kogar? You, because at this point might get lost.
Okay.
So are we saying that suppose given complications like Haze which are bad, you said it's a good procedure compared to, say, a -3, LASIK versus PRK. What is the advantage of doing PRK? One thing you said is the strength of the cornea is maintained, integrity of the cornea, there's no lifetime tension of a flap displacement. So except for what reason would you not want to do PRK?
Yeah, I was just coming to that. So in the PRK, you measure on the corneal surface and you ablate the corneal surface. Whereas for the other procedures, you actually measure on the surface, but you're ablating deeper, which exactly is not what you're measuring. You're thinking that it's going to be the same there. It might not be the same if your cornea indulation. So any which have a corneal pathology, I think it'll be the better procedure, PRK, than a
Rajesh, can I also now put this question to you?
-3 diopters.
Normal topo, normal pecchi, -3. What are the plus points of either?
I will go for LASIK if everything is fine.
Yeah.
Both the options are okay.
Yeah.
I will go for LASIK except.
No, why? Why?
No, I'm telling you, I'm coming to that. Except in an individual who is involved in contact sports and perhaps and perhaps an army official.
Okay.
These are the 2 indications of PRK. Otherwise, in any other individual, I'll go for LASIK. The reason is this, because of the presentation that I did, that even if you have a clinically insignificant haze and the person is having 6/6 vision and there is some granularity on the surface. Now, today is the era of these multifocalities and every individual will have cataract. Even the cataract surgeon will have a cataract. So later on, even with a minimal haze, which is now clinically insignificant, you can have a clinically significant haze also, which can, reduce the quality and quantity of vision. But even if it's little bit of haze, it will have an impact later. So, I mean, in most of the patients, there will be some impact. This is what I feel.
Okay, I'm not going to take Sartaj's opinion because I think he also doesn't do. Yeah, please. Yeah, please.
About the haze, like I've been doing a lot of PRK about the haze, only one message I would like to give is, it is unpredictable.
Yeah.
You cannot tell in any case that this case will not have haze.
Absolutely. Correct.
So you have to keep your fingers crossed. We had a case couple of days back. The guy had come from Australia, got married, got a PRK done, and he had an infection in both the corneas, and he had to fly back in 3 days. So there are some issues with the surface ablation.
I think that's
Yeah, I just sort of wanted a lot of discussion on this point because, mind you, in spite of the extremely high-tech centers where there is a lot of options, so person has got an option of LASIK, femto-LASIK, SMILE, and PRK comes very low. But these high-tech centers don't form more than 10% of the centers in India. 90% of the centers, Rajesh, my observation is they are shifting. Europe, 50% surface. 50% has gone back to surface treatment. Okay, you can't, this is a shift I'm observing. I'm not in favor of, but I like to use all these very knowledgeable people to elucidate the pros and cons. Whether you like it or not, you're going to see so much of surface treatment. And therefore, he showed a slide of US Army 30 patients. I have taken out a study of US Army 28,000 patients. They say we gave informed consent And we are willing to do LASIK and surface treatment. More than 80% chose surface treatment. Who wants attention? So we did it. And they claim insignificant haze. In 28,000 US Army, the Army itself has got LASIK machines. The US. So this is a topic which is going to stay. And thank you, Rajesh.
Actually, I will totally agree with Dr. Grewal, because this is extremely, the only fact is that it is extremely unpredictable. You can't predict which patient will have haze.
Correct.
So maybe there are some other factors, racial factor or whatever factor there that are involved in creation of haze.
Correct. Thank you. The next, I think, is yeah. Yeah, so PRK was what was called before the keratome was invented, and when the fashion went back to surface treatment in the last 5-10 years, it is called advanced treatment when you either use alcohol or you use mitomycin or use a epithelial separator.
No, I want to know the difference between haze between the trans PRK and DSA. Is there any difference between the haze?
No
or
difference.
Is the same?
Absolutely no difference based on literature.
Okay. So I think who's going next? Yeah, we have Dr. Khoker, one of the most experienced. Nobody left? Good. That's good. Yeah. We'll take that after this, because it's I don't think that's a sign. I don't know, in fact, but it is there. Whether I know or anybody knows, and it is there. A large portion of the treatments have become surface. Let's do it after Dr. Khoker's
I think the reason is that people don't have to buy a keratome or a machine to cut the flap, so you can do the surface. Because when it started on surface, it's the economy which works. Because you just buy a machine, that's excimer, that's about it. You don't need anything else. Whereas if you want to do a flap with a blade, you need a Hansotome or a blade. And if you want to do a femto laser, you need another laser for that. So it's the cheapest format possible, and yet, as everybody says, unpredictable. I fully agree, it's fully unpredictable. But at the end of the day, I think most of these people sitting in the peripheral centers are still doing it because of economics only.
I would just like to make one comment. I think the basic reason is post-LASIK ectasia. In PRK, there are very few cases reported with ectasia. The main reason for shifting to PRK is taking care of the post-LASIK ectasia.
But it doesn't take it away totally. Dr. Grewal, it still has. Even PRK has ectasias, even SMILE has ectasia. So there's
I think
none
Dr.
of the
Khoker is going to talk about SMILE. And
the pros and cons, they said. So I'll just tell you my 1 year experience. That is enough pros and cons for me. So, so what is the difference here? Initially, you make a flap and zap. You need a machine to flap or a blade to make a flap, and then you take it to the other machine and zap with the excimer. When they realized you can make flap with 2 modalities, you can use a blade or you can use a laser, which was femto laser, which was 10 to the power minus 15. Then they realized that if you compare the statistics, the blade are not faring as good versus the laser. So they saw these cases and realized that the standard deviation of the shift of the thickness is about plus minus 20. That was the maximum. So it was a very precise cut. So I think people got idea, if you can cut it so well with the femto, why can't you get away with the excimer, have 1 machine only? So you can have cut 2 lenticules, make the cornea the power which you want to give it, and you take the lenticule out, and that's how this thing has started. So because the effect on the cornea of the femto done because of the femto Lasik surgeries, they have come out with conclusion. So I think that's well taken. Okay, so 2 important things. The strength of the cornea is everybody talking about. Ectasia has nothing to do with the strength. Of course, if the cornea goes thinner, more chance of ectasia, but you can have it with the -2 Lasik also, and you can have it -1.5 PRK also. So there are some factors which nobody knows why they're happening. So whatever studies I'm quoting is in favor of the SMILE, because what they found out that if you see in these patients, there was 7 times more strength in the cases of SMILE versus the Lasik for the same power. And since you're not cutting the nerves all 360, your dry eye also is better. So SMILE is better for the surface things, for the corneal denervation and the dry eye, plus it gives the more strength. And the strength was measured on Corvus and ORA, and these both systems are working, but they're not foolproof. There's still patients in which you can't pick them up well, but that's what is the gold standard as of now. What comes in the future, we don't know. So we can say it's better, and we just have to wait and watch and what happens to these patients. So what happens is you basically create a flap and take the lenticle out. You have to be precise, docking of the cone, and I think I'll show you a video and that'll explain everything. Okay, so you always have to cut the posterior flap first, because if you cut the anterior first, the light is not going to go beyond that anterior flap, which is opaque now because of the bubble, and posterior will not cut. So cut from the back, come anteriorly. So the first, once you've done the docking, that's the center fixating light for the patient. It cuts from outside in, that's the posterior wave going. And then the anterior wave, which is about a 0.5 millimeter bigger, 1 millimeter bigger, and it starts with the center out. This is not a edited one, so this is giving you a complete. So you just see this is the actual time taken for the surgery. So I'm not going to reduce the speed, increase the speed. So that's the second one. It's gone across, and you got an incision at the side here, and you're good. So that's what the machine has done. It has created the bubbles inside, and it created the layers. Now what you have to do is you just have to separate these layers using the skills, and that's where the skill is required. If you've done 5 patients with the proper splitting of the layers, you're as good as anybody else who's done 50. But of course, the experience counts. The more you do, the faster you can go. So you create a pocket now, open up anterior. These are the layers which are already cut. Then you go with a separator. You go to the anterior first, go up in the middle. I think I should run fast. This is rather, okay. So once you go here, you have separated the anterior one, and you separate it all around. The cornea looks very bad right now because all these bubbles are there. The next morning, all these bubbles are going to be gone, actually, and the cornea is going to be crystal clear. So we have seen the patient which have come up for follow-up after 1 year, Lasik versus this one. Lasik still has some interface issues here and there, but the smile interfaces are absolutely clean. They're clean. So once you've taken out both, it's cut from all around. You just hold it and pull it out. And that's the lenticle gone out, and the procedure is done. To wash or not to wash, again, some people wash it. I wash inside, so I wash all the debris which are there, and that's about it, and that procedure is over. So it takes much less time than the Lasik because you're doing on the one procedure. Now this patient was done on Lasik. When you cut the cornea 360, you have little irritation. So this one is smiling more, so this was a smile procedure, fine. All right, so what are the shortcomings of the smile? Till October 2018, the FDA had not approved it for the toric one. So -1, 8.25 spherical equivalent, or -0.5 cylinder was what the FDA had allowed till October. In October, they come out last year that you can go till -3 to 3 diopter of the astigmatism, and about -10 spherical equivalent, which is pretty high. So the cylinder has been incorporated, and I think people are using cylinder. Dr. Grewal and all were using cylinder here earlier also, but now you can say FDA says so. So it is stamped by the big papa there. All right, so ectasia can happen with this also. You can't tell patient the ectasia is thrown out of the window. No, please, whenever you're counseling this patient, you have to put this into right perspective. You tell them the procedure is, all the complication of Lasik can happen in this one. All the pre-op workups of Lasik holds true for this. So I'm not going to go for the pre-op because whatever Sataj said is holding true for this surgery as well. So if you have issues of ectasia and all, and if you have keratoconus, this is a big no. So all the indications as of them are here, except if you want to keep the strength. You have the borderline case, you can still go away with the smile as compared to the Lasik. Okay, so what are the complications? Of course, you'll have complications. Since these are the soft suctions, these suctions are not very firm, like the femto, the good old surgeries in which you have good large, when you're using Hansatom and all those, you're having 60 millimeter pressure. So these pressures are low. So the patient, if it moves, you can lose the suction. So suction loss can be there. There could be areas where the laser does not fire because the cornea was dry. So the laser didn't fire, or there was some debris which you didn't clean up. So that area is going to be sticking. You'll have area cut around, but that islands, those islands called black spots will be there. So when you're splitting them, you might get stuck there. But if you're if you're a good surgeon, you can actually manage those ones. But it can be avoided totally. You can have bubble layer, which is seen for first few days and then it goes away. Epithelial defects can happen in these ones, but that's a short thing, and on the surface can go away. You can identify wrong planes in the beginning. It happens with everybody. We also burnt our fingers. You're going under the posterior one first. So once you split the posterior, the lenticule is stuck to the anterior part, which is about 120 micron, doesn't have a strength. So you can't push it up. So that's why you should do the anterior dissection first. And then you can push it down towards the stroma, which is still about 400 microns down there. So you have the strength. You can actually push it and poke and do whatever you want. So that's why the anterior has to be split first. So that can happen. You can have a tear of the capsule. You can have the tear of the caps, and the incision can also get torn. So you start with the big incision, 3 millimeter, then come to 2 millimeter, because most of the time in the beginners I've seen, the incision does get big. You can go to 3 also. Dr. Maipal, I think, usually uses 3. It depends on what is your surgical acumen in that one. And you can have post-op epithelial ingrowth is still possible here, so that's why you keep eye on that. You can have inflammation to some extent. It was happening earlier when we were using higher energy, but now with the energy modulated, the interface things have reduced and things go past. So day one, we have 6-5 vision in about 90% of patients. Initial few patients, which we did about a month, the first 1 month, we were also skeptical. We were not going dissections very well. We had more reactions, and we are using high energy. Now we got energy very low, so the damages to the stroma is also less. Okay, so I'll just go. So you can have lenticle tear. This video looks bad, but at the end, the patient has 6 vision on by the end of 1 week. So half the lenticle has come out, half is not. You see this one? This is not a complete lenticle. The one which you saw in the beginning was a complete lenticle. So go ahead again and hold it. Now what is happening? You see the patient is not cooperative. So best in this is to hold the eye and do it. And sometimes it's the anxiety of the patient which is causes. You can see the incision has also gone a little bigger, and the lenticle has come in 3 pieces, but it's come totally now. And then you can check it out on the surface. So this can happen, so don't get disheartened by that. You can have suction loss, because I told you the suction can be lost. So you put in a thing, it started working. Okay, it's working so well. If what you notice now is, you have a pointer here? Yeah. So you see the conjunctiva started coming in. Now this is time when you should actually stop and dock it again. But for the beginners, you think it's going to get away. So it's still going on, and the conjunctiva is coming in, the machine has stopped working, and suddenly you realize that this is gone. Now see, it's gone. The patient has moved it. So you have set protocols depending on how much percentage you cut on the in the flap, and you can again use the same PI and go ahead with the surgery. So that protocol I'm not discussing, but you have protocols in place. You can take care of that. This one we docked it again, and you see we cut it again, and we have 3 layers, but we took out the layer in the middle, and the patient was again okay, fine. Now you can have the suction at the end of the surgery also when everything is done. I think my time is less, so I can skip this video. Okay. Now that is what is a black spot, right? So when you're going inside, you're splitting. This will split very easily because there's bubbles all around splitting 2 layers of cornea, whereas this is going to be a little dicey. So for the beginners, you have this one. You've got to be a little, you have to take a little sharper instrument than a very blunt one, and you can just actually go through it, and it's possible to do it. So far, I have done 506 cases. RP Center has done more than this. I think maybe the double number, because Dr. Tityal's unit does it and I do it. So the minimum I used was a 1.75 diopter, and -9 was the maximum I used. I was following the FDA, and I was using up till 1.25 cylinder, but now I started using more. So last week we did about -2 patients, and they were good. Okay, in the first few patients, the vision was hanging around 6.9, 6.12 for the first 2-3 days, but it came down to 6.6 eventually. And all my 1-year follow-up patients, none of the patient is less than 6/6, so that's a good sign. And longest follow-up I have is about 12 months in these patients, and I think we can overcome these difficulties like the suction loss and all that. You have to have patient counseling. In fact, I give patients Alparax before, a night before, so that they're more calm, especially for this one. Whereas most of the patients are doing good. And one patient which had the suction loss, we did the Dishler's technique, and the patient's 6/5 vision. And that doesn't mean that if you have a smile, you throw your excimer away. So sometimes you get stuck with the excimer. You had, with the Lasik, you have to convert, the smile you have to convert it to a Lasik procedure. So you still will have to give a machine. I hope, Dr. Grewal, you haven't thrown your machine away yet. I think you never know when you need it, but it is a good thing to keep it back. You can't promise them 100%, but because 100% is not possible in anything. So software don't have a 1 millimeter. I want 1 millimeter incision on the side, so that if the main incision somehow is you're not comfortable, you can make one opening from the side and do it. I call this a bimanual technique, 2 incision technique, which I follow. And with that, you can actually cover all the 360-degree easily. The software is a little iffy, because in case there's a fiber or something, you can't actually see it on the table. You have to go to the slit lamp and come back in case it's there. And optics could have been improved on this one. Foot control on the microscope is not there, but in RP Center, they've given us foot control. So you can ask them to get your foot control, so that the movement of the machine is with the hand. So if you're doing a procedure and your hand has to be left and you have to rotate the knob, it doesn't work well. So you can have a foot control, so that way both the hands are free. And you can add an OCT there. In case you have a lenticle which is left, so you can always see it on the OCT if it's a small lenticle. Small lenticle in the periphery can be left aside also, but if it's a big one, OCT can help you, which is not there on the machine, but I think we can ask these guys to add on to that. And so to conclude, SMILE is safe. There was no loss of vision in any of these patients, and it was predictable because there was no regression in any of these patients, and for the cases of low to high to moderate myopia. Thank you.
Thank you, Dr. Coker, for covering this very well. If you could join us now for a little panel. So how many people are interested in LASIK and doing LASIK themselves or taking their patients? Say here in the audience. Very good. So there's so much interest in LASIK, and I promise you, the people who are not yet into it, it is a need of the hour. As an ophthalmologist, you must get involved in refractive surgery. And I humbly request you, today there are a lot of, starting from a youngster who's doing thing, anything. We have got one speaker less, we have got 10 minutes. Just ask anything, how I should start getting into refractive surgery, what to ask the patient, anything in your mind, ask us, and I think we should be happy to interact with you. Just stand up and ask the question. Yeah. Yeah, Sataj, IOL power calculation after.
For the patients who are post-myopic LASIK, it's pretty easy. You have some very good formulas on the Ascaris website also. It depends on how flat the keratometry is. Anything 39, 40, even if you go with whatever's coming in your optical biometer, you will tend to be pretty accurate, especially if you go with one of the newer formulas such as Barrett or Hill RBF. If it is very flat, then it's always, but it's important to always double check it with the True K, with the Barrett and the Hill RBF post-refractive formula that is available on the internet. The newer machines such as the Pentacam AXL actually included in their software also, so they'll give you the printout right there. I think in those patients, the most important thing is to take data from a couple of different locations. Use the keratometry that you get from the Pentacam also, the net corneal power. Compare it, and then I think in those patients you will have the first couple of cases, you will have niggling issues. You will learn as you go along. There's no easy answer for that. You have to take data from multiple areas, see what is matching up, and then take a decision. That's what I do. I take the data from I'll take the Pentacam, I will take the IL Master, I'll take the LensStar. The results, so obviously, they're actually not bad, if you ask me quite honestly. It depends. If the patient has done well after LASIK, again, especially myopic LASIK, they do well after cataract surgery also.
Okay. Thank you, Sataj. Yeah. Rajesh?
IOL power calculation, are they reliable, or do we need to do a little bit of more of
Rajesh?
You use the formula actually, like the Haze cell formula is best for post-refractive. So you can use that formula in the machine, and as Sataj was mentioning, ACRS calculator is something which gives a reasonably accurate value, although you can have surprises after post-refractive. There's no foolproof method as in a normal like virgin corneas. You don't have a foolproof method, but
so the other question,
reasonably accurate.
The other question is, before doing LASIK, it's important to know the white to white. Now, I have the Sirius, and it does give the white to white, but I have seen many times that this value doesn't correspond very easily, and when you actually go and put the ring there, then you notice that it's not according to what you've thought. So what are your ways of cross-checking on the white to white before deciding? I mean...
so see...
Rajesh, we have got our last speaker. He's just made a late entry. So, Dr. Rohit Shetty, thank you for joining. Yeah. And let's finish this. Yeah.
Answer the question. It may take a minute for them.
For setup, yeah.
Hello.
Yeah.
I just want to know, there's a young patient who's wearing contact lens for 10-15 years now. He has a mild dry eye problem. So would you advise him LASIK or SMILE? Which one will be better for him?
If I ask Dr. Grewal to answer this question, he already told me that he does SMILE for everybody. So I won't give him the chance to answer this question. And Rajesh, yeah.
Sir, first of all, I would like to treat the patient for dry eye, because even if we do, results have shown that immediately after, in a normal individual, after smile, in the immediate post-op period, the risk of dry eye is lesser, but at 6 months, the results are comparable as with Lasik. So whosoever is having any problem, I mean, there is some degree of, denervation, etc. there with both the procedures. So whatever be the procedure, if the patient is symptomatic for dry eye, we should treat the patient first and then only think of doing any procedure. Improve the ocular surface and then go ahead and do it.
Ready, Dr. Shetty?
Yes, sir.
Okay, please. We now have Dr. Rohit Shetty, who has large phenomenal experience in refractive surgery. Thank you.
Thank you, sir. And my talk today is advanced surface ablation. I had my own IC up there, so I just had to finish and come in. I'm sorry for that. These are my financial interests, grants from all these companies to work on my work. One of the reasons people always have when you're looking at a PRK, these are the questions which comes to your mind. This is the reason why most of them don't want to do a PRK. The pain, you have haze, is really biomechanics an important factor? There's always a question mark. The big challenge is the fear of wound not healing well. It's not getting into your right one. So my talk part is about a little bit of the wound healing and its implication in deciding your PRK. The second half is about the results and rituals to make it better, what I consider in my clinic. So anything on the cornea, if you even scratch your epithelium, there are 3 waves of healing. The first wave of healing is always pro-inflammatory. When people say there's an inflammation, if there's no inflammation in your body, then we'll not survive even for a minute, even a second. Every single cell in our body, which is the first line of defense, is inflammation. And so is in PRK, so is in Lasik, everywhere. So you have inflammation, they change the keratocytes. The second is pro-fibrotic. That is where you start getting the scar part of it. And the third phase is when the scar gets removed. This is how a healing of a PRK happens. This is very interesting because this is what drives, this is where our fear is. If I get haze, the haze is if these factors are more than necessary in your eye, then probably the second phase never happens. And this is your phase you get. It's a phase which keeps going, so you have more and more scarring. So that is why out of 10 PRKs you do, 1 will have haze and the rest of them don't, because they have higher level of basal level of inflammation. It's like higher level of hemoglobin, higher level of sugars. Exactly the same thing, you have replica of that. So the challenge always been is we can't find prior now except for the MMP9 one, which you can check in your clinic. Epithelial thickness is an important factor because that's what you're going to feed into your machine. The second factor is if you're using a manual one, how easily the epithelium comes out will tell you the level of inflammation. For example, these factors here, which I've said, which is responsible for the haze, actually, if you're mindful in your removing epithelium, one which comes very easy means these factors are loaded in your eye. Once it comes very tight, means that it is good eye. That means sometimes we don't care. When it comes very easily like a capsule or excess, you're so happy with it. It came so easily. And that patient has invariably a bigger chance of developing haze because it's already higher level of inflammation. So when I get something which if I have to do a manual one, if I get it very easily, what I do is I change my steroid pattern. I use a stronger steroids. I use doxycycline in them because you have to change the way it's done. And this is just a proof to you to see that we did work, which what I just said is what we have already done in a clinic by studying these epithelial cells. There are different types of doing PRKs, manual, epithelial removal, laser. Now Schwind uses a trans-PRK and Alcon uses the same thing, which is it is a one step. You press the foot pedal, it's done. One of the easiest procedures, I think, in ophthalmology. When we compared our results with both Contura and Smile, I'm not going too deep into it. It was matching. there was no loss on best-corrected vision, uncorrected vision, efficacy, and all the index was normal. But where it really scores is, if you just Google it on your PubMed, PRK and Ectasia. Very, very few or hardly nothing. Lasik, a lot. Smile, we are adding to the PubMed now. It's getting there. And there are a lot of unreported ones also out there. So it is quite safe as far as your biomechanics is concerned. We published this work last year about comparing the biomechanics of all the procedures. And you feel that this is the paper in which you can see, it's a freely downloadable one. You can see the PRK was probably the strongest. It's giving you the strength. The second was Smile, and the third is your Lasik. But still we don't want to do it because we don't like it, because we are worried about Haze. What happens? And I've given you the reason why we get Haze. So for these, we have to have some rituals. For me, the ritual is this: your symptoms, how much allergy are you having? You have inflammation, and now we don't have too many things. I think Dr. Grewal sir uses MMP9 a lot, but it's a costly tool. Patient has to pay 1,000 rupees more than that. And the life and environment, what kind of a life you're living in. If you're working in the environment in a factory. And this is something as very simple score I use in my practice to just gives me an idea that if it's a very high score, then PRK will definitely have a more Haze. And we have issues with the nutrition also, because we as ophthalmologists consider that we don't need nutrition in ophthalmology. And that's such a big myth which has been followed and which has been driven, which probably we need to take it off. So I mentioned intraoperatively, I always look at how easily the epithelium comes off. Mitomycin, not for all patients, anything more than 35 to 40 microns ablation, which I use. There are a lot of new alternative to mitomycin. Saha is one. It is again a mitomycin cancer drug which looks at the fibrotic process. I'm not going too deep into it. This is probably what you're going to see, a good alternative to mitomycin in the next maybe 2 or 3 years. And you can see that mitomycin causes death of keratocytes here. As you see, there's hardly any keratocytes on this side. And see, the green ones, it reduces Haze, Saha, but it doesn't kill it doesn't kill the keratocytes. That means there's no collateral damage like mitomycin. And you want something which does not cause collateral damage. This is something which we got published also, and one of the best videos at the SCR is by Dr. Ritika, where we soak the bandage contact lens in AccuVeil drops. It gives you exactly the same feel as a post-op is like a Lasik. The patients hardly feel any difference, and we did the Wong-Baker scale, hardly 0 to 1. Yesterday, Gaurav presented the same thing. And if you should try it, it's a very simple thing. You inject the AccuVeil, which is it's a preservative-free, into a contact lens bottle, a contact lens solution, keep it for 10 minutes, and use it after 10 minutes. The AccuVeil gets absorbed. I have no financial interest. Only thing I'm talking about AccuVeil because it's a preservative-free one. It's difficult to get it. They also have a new drug, Ampinac, I think, which you can use, which gives you the same kind of a results. So these are the scoring system. I'm a big fan of nutrition. And somebody who's an asthmatic, I always get an IgE done because they are always allergic to one or the other component, including your fumes. So that can create an issue. So post-operatively, these are my regimen. But I change it if I feel that they have a higher score, higher allergy, if they're asthmatic, or they have more of dryness, or a long-standing contact lens wearers, because I feel that they are the ones who are issue. You have to be a little mindful, and you can't have a blanket treatment like how we do it for Smile or Lasik. A little bit of customization is necessary, and we have to sometimes change for every patient you do. It's a little, you feel it, you don't do it on a spinal level like how Lasik you do, because most of it then it's the same regimen all the time. PRK needs a little bit of tweaking. The reason it's important to look at vitamin D is it's a wound modulator. It helps in a lot of things on this. You have the receptors on the epithelium. God has given the vitamin D receptors on the epithelium, which can manufacture vitamin D without need of sunlight. And I believe that if he's put in something there, it has to do something. It can't just be there without doing anything. And one of its role is wound healing. And you can see that it has a big role in work on the myofibroblast. And that is why it is important that anything to do on the cornea, which I do, I try to be very clear that I take care of the treatment and then do it, because that's where you end up in haze-free process after surgery. My last step, PRK is just not one blanket surgery like I mentioned. You have to customize sometimes to every patient you do, and that's when you get your perfect results. Thank you.
Thank you, Rohit, for covering that extensively. Before, just one question. Your one slide said post-op steroids and cyclosporin. So do you give both in PRK to every patient?
That depends on if the patient has not a contact lens wearer and he's not allergic, he's not asthmatic, then steroids would suffice. But most, I may be a little biased here. Most of my patients, Bangalore, they are like 12 to 14 hours computer professionals. And if I don't give them something, they invariably come back to you with dryness. So this helps in some way.
Thank you. Could you join us for the last few
Yeah.
questions if there's time? Yeah, any other question? Yeah, please. So there's the youngest fellow want to start with this answer. How do we graduate to refractive surgery?
You just have to start. Yes, PRK is a very good place to start, but then the post-operative care, and as Sir has very rightly pointed out, that does require experience to understand how to manage the patient post-operatively, what drop regimen you want to give. There are a lot of subtle nuances over there.
Sartaj, I got the gist of it. What I would think is, he's not a practicing ophthalmologist, okay, at your age group. How do we get into refractive surgery? The first thing what he said was get into it, okay. Next time you see a patient with myopia, offer refractive surgery. The biggest impediment to the growth of refractive surgery is most of the ophthalmologists not offering refractive surgery. Then you find a center near your town. Today there can't be a town where there's no refractive surgery center. Okay, in Bombay we have 52 centers. Okay, our machines are used once a week. They all are more than happy if a neighboring ophthalmologist brings a patient. Start observing it. We can't go for these long fellowships, 3 months, 6. You cannot close your clinic and go. It is, as Dr. Rohit Shetty said, PRK, you put a speculum and just press the foot pedal. How many days is it going to take you to learn that? Even if you do Lasik, you just press the foot switch and the keratome moves forward and back and makes it. The technical part is not like phaco or retinal surgery. It's not going to require you to, go for an intensive fellowship, okay? If once you're mentally there, that you want to do it, and you start this, I think you will have very much. Rohit, would you like to add, and Dr. Grewal?
First, have access to machine. Second, have the minimum basic training. Third, get the patients, and have 2 objectives very clear in your mind. First is, I want to give good quality vision to my patient. That should be your first objective. Second objective should be, I want to avoid complications. So that will be the key thing to develop your practice onto it. Technically, it is not a very high-tech rocket science kind of a thing. Avoiding complications, if you can do a good preoperative workup, you have won the battle.
Rohit,
I think Sir and him has summarized everything. Yeah, you have a question?
Is there any age limit for refractive surgery? And second question was that, is there any refractive surgery for near vision which you are doing?
Age limit is, if you are able to wait till at least 21 years, it's the age limit.
And maximums?
Maximum, there's no age limit. If the patient wants, we've done at 50 also, but knowing very well that they need a cataract surgery, given them the option of other options. Your second question is about laser-driven procedures. Most of the machines now have it. Schwen, Mel 90 have their own versions of it. But after 40, your optics is completely different. It's not a very synchrony of cornea and the internal optics. So there are people who are very happy and people are not happy. But you have an option.
So for near vision, whether there is any refractive surgery?
Near vision at the moment, mono vision is the most successful. Yeah, madam. Yeah.
How effective is the Lasik in correcting?
Yeah, Grewal sir.
It is effective. You can correct up to 6 diopters, but the issue is high regression, and then the optical quality of the cornea in these cases is not very good. So don't expect them to have a crisp 6x exhibition. And then you have to do a good cycloplegic refraction to make sure that you are correcting it completely. I have done hypermetropes, but I am not very happy with the results.
I do hypermetropes up to 2, 3, and I find the regression is less in the older age group, you know, the 40, 45, they have less regression. Maybe, you know, the cornea is stiffer at that age, and that's why. Yeah, yes, sir. Sorry? What do you look for in your machine? In your machine you will purchase? See, first of all, you're not going to purchase a machine, okay? So I have not yet purchased a machine, okay? I do 2,000 eyes a year, and the medical college, I do private cases. I don't own a machine, and I don't think it's a clever idea to own a machine. So the idea is you find a machine close to where you are, a neighborhood machine, and just like it's not even just like some phaco machines are good. These are pretty standardized machines. They're charging you $500,000 for it. You know, it's not that the machine is going to make your patient blind. It's just so important that you must find a particular brand, particular model machine. That is hardly an impediment. So I think that should be. Yeah, madam. Rohit, sir.
See, one of the it's working. The most commonly, it's not a. I think it's very rarely seen complication of Lasik, provided if you're using your sterilization procedures very correctly. And many times the infections are noted because there is some breach in how you take care of your Lasik versus your cataract. Cataract, you have sterility, you scrub, and a lot of times people take it really lightly. They don't even use gloves here. Most of the time we get sterile infiltrates. That's one of the most important thing because they react, because most of them have meibomian gland dysfunction. The known commonly caused infection is microsporadial one, which is quite missed many times, and early scraping and other things is necessary. But infection, touch wood, has not been a major bane of refractive surgery so far, because
I think his first point is most important, that you have to treat it as a OT procedure and not as a casual procedure. Yeah. Sataj?
Again, digital calipers is a good way, but it is important to once again corroborate between the different machines. It's also a good idea to first take the digital caliper, take whatever machine you have, such as the Sirius, and do the digital caliper in the OT under a microscope properly, compare it with the value of the Sirius, and understand an algorithm that this is the usual disparity. And then you'll understand how to make more out of the Sirius values that you're getting.
This is a good question. Dr. Rohit Shetty?
My major part of my work is Lasik, the flap. Then comes your smile, and PRK more or less in the same level. I may be differing here. The reason is when you're looking at a very thinner corneas, for some reason we get a lot of them. PRK is not known to cause, at least I don't see it reported anywhere about having a problem. So I just want to safeguard myself better.
Yeah, Dr.
I started doing smile 4 years back, and once my smile volumes crossed 80% of my refractive surgery, it was financially not viable to maintain the Lasik machine. So I've stopped doing Lasik completely.
So what is your name, sir? Ambadkar, sir. I think I have to rephrase your question for this esteemed panelist. If you have Dr. Grewal, whose net worth is more than $100 million, and he has all the equipment, and Rohit Shetty is little more, 10 million more than that, this answer will be different. So this answer should be compared to 95% of the ophthalmologists who will do their Lasik at a center where there's just one Lasik machine with a microkeratome. Someone has to answer that question also. So we cannot start saying when the corneal thickness is 490 and then the femtone smile, and when it is 482 then the smile, and when it is the topo shows Q value of 0.22, it is this, it is this. That is in a center where RP center, Dr. Rohit Shetty center, Grewal center, where you have 22 machines and each machine has to be made to pay for itself. So you must search the correct indication for each machine. Okay, if you are going to a single standalone LASIK center in your neighborhood, what will be the answer? Would you do more of PRK? My conclusion, since I don't fall into these, if I have to answer this question, most important complications occur in ophthalmic surgery. You get endophthalmitis. Have you stopped doing cataract? How many times you have spoiled the cornea while doing phaco? Do you stop doing cataract? Stop doing phaco? Complication. The most important thing Dr. Grewal said, it is unpredictable when you'll get haze. Otherwise, surface treatment is the most, logically thinking a good thing. And you take the precautions. Dr. Rohit Shetty enumerated so many precautions. Take all of them, and then it's just probable if you get a haze, you live with it. That's what is my answer. Thank you. Thank you, everyone. Thank you, panelists.